Hello everyone. In this week's lecture and next week's, we will discuss the topic of restoration of endodontically treated teeth. This topic remains a controversial subject because of the confusing range of opinions presented by dentists and scientists. There's also a continued evolution of dental materials and techniques, which makes the decision even harder. Therefore, as clinicians, we often face dilemmas regarding the most appropriate way to restore a tooth after a root canal treatment. The aim of this week's and next week's lecture is to give you some guidelines and recommendations to help you make the right choice for your patient, hopefully. First of all, let's look at some studies that have proved the synergism and the importance of the endodontic restorative interface, and we should look at them as continuum for tooth rehabilitation. The first study is a systematic review that was done in the Eastman Dental Hospital in London in 2008. They found that there are 4 factors that will enhance and improve the outcome of your root canal treatment. These were the preoperative absence of periapical radiolucency, the root filling with no voids, and a root filling that extends to 2 millimeters within the radiographic apex, and most importantly, a satisfactory coronal restoration. So if you have these 4 factors in your root filling, then the treatment is most likely to succeed. Another radiographic studies that investigated the importance of coronal leakage and on the periapical health of root canal treated teeth. They assessed radiographs of root canal treated teeth, and they assessed the quality of the coronal restoration and the quality of the endodontic treatment, and they scored both and assessed the outcome of the treatment on the periapical health of the tooth. So if they found that if the quality of the endodontic treatment based on radiographs and the quality of the coronal restoration were both good, then your success rate is most likely to be above 90%. However, when the quality of the endodontic treatment seems to be good on radiographs, but the coronal restoration is poor, the success rate drops to 44%. And when you have a poor quality endodontic treatment based on radiograph, that means voids, short root fillings, improperly filled root canals, but you have good coronal restoration, the success rate was 67%. And when you have poor endodontic treatment and poor quality coronal restoration, the success rate was the lowest, and it was around 18%. So these are examples. In radiograph A, you have a good quality endodontic treatment, of course, based on the radiograph, and you have a good quality coronal restoration, good marginal seal, then the success rate will be very high. However, when you have poor endodontic treatment, but the coronal restoration is good and you have good marginal adaptation, then the success rate drops to 67%. But when you have the opposite, if you have a really good, nice root filling, but the coronal restoration is poor, the success rate will be lower, around 40%. And when you have both the coronal restoration and the endodontic treatment are poor, the success rate is around 18%, as you can see in radiograph D. So in this study, they concluded that the quality of the coronal restoration is more important even than the quality of the endodontic treatment itself. So regardless of the quality of the endodontic treatment, if you provide a good coronal seal, then the treatment is most likely to succeed. The last study highlights the importance of the temporary restoration as well. So not only the quality of your final restoration is important, but also the quality of the temporary restoration is important. This was a clinical survey of 100 patients, and they looked at the factors that are likely to cause pain during and after endodontic treatment, and they found that unsatisfactory temporary restoration may cause increased risk of pain after endodontic treatment. So these studies showed the importance of the coronal restoration for the root-filled teeth. Now, we have this idea that root canal treated teeth are more susceptible to fracture when we compare them to vital teeth. And this is quite right and it comes from the fact that teeth will usually need root canal treatment if they are badly destructed and badly affected by caries or fractures or by trauma, and they lost the majority of the coronal tooth structure. So these teeth are weak, and at that stage the teeth will most likely need root canal treatment, and that's the reason why we assume that root-filled teeth are more susceptible to fracture when compared to vital teeth. Another reason is when you have an immature tooth that undergone, for example, trauma, and it needs root canal treatment, these teeth are not completely formed. The roots will be thin and weak and shorter than completely formed teeth, and therefore they are weaker than the vital teeth. Okay. Another study that highlighted the importance of the coronal restoration is a study by Weyer, who found out, or who tried to find out the reason for extraction of endodontically treated teeth in different practices, and he found that the most critical factor to cause extraction for teeth after root canal treatment is restorative failures. So 60% of teeth were extracted after root canal treatment because of restoration failure, while 30% of these teeth were extracted because of periodontal problems, and less than 10% of teeth after endodontic treatment were extracted because of endodontic failures. Okay? So failure of restoration is a very important factor for the failure or extraction of root canal treated teeth after a while. Okay. So this is the conclusion of Weyer's studies, that most endodontically treated teeth are lost as a result of restorative factors than as a result of failure of the root canal treatment itself. Now, the key for success, or the best plan for success, is to begin with the end in mind. So before you start your root canal treatment, you should carefully examine the tooth for caries, fractures, marginal defects, and the restorability of the tooth should be assessed, the occlusal function of the tooth, the periodontal health of it, and we should look at issues such as biologic width, the crown root ratio. These should be evaluated before attempting a root canal treatment. If these factors are deemed satisfactory, then you can include this tooth in a comprehensive treatment plan and start your root canal treatment. Whenever possible, practitioners should remove all existing restorations and caries before initiating root canal treatment, because you know the Abbott's study where they found that cracks and marginal defects and caries are not always detectable on radiographs underneath these restorations. So we should remove the restoration, assess the restorability of the tooth before attempting root canal treatment. And this will allow you a more accurate assessment of the restorability of the tooth. So you can see that after removing, you may look at the tooth on radiograph and see, yes, it's restorable. But when you remove the restoration and assess the remaining tooth structure, you will see that there are caries that were not visible on radiographs, there are marginal defects, there are cracks, and these make the tooth non-restorable, or you may need another procedure before attempting the root canal treatment, such as crown lengthening or orthodontic extrusion to increase the coronal tooth structure. We use this acronym PICOFA to just remember the factors that we should keep in mind when selecting the restoration and when assessing the restorability of a root-filled tooth or a tooth that's planned for root canal treatment. We should look at the periodontal health of this tooth. We should look at the gingiva, the periodontal tissues. Is this tooth mobile? Is it a grade 2 or 3 mobile and then it's a hopeless tooth that needs to go? Are there any pockets? Pockets can lead you to the diagnosis of vertical root fracture, for example. Is there a recession? What about the crown root ratio? Does the tooth have enough anchorage or enough root length to support it after root canal treatment? And is there an invasion? Will there be an invasion of the biologic width when we attempt to restore this tooth? Do we need another surgical procedure to increase the coronal tooth structure? And then we should look at the endodontic status and the root canal anatomy of this tooth. Can I do a good quality root canal treatment on this tooth? Has it been root canal treated before? Are there separated instruments or ledges or transportations or perforations that cannot be adjusted? Does it need a periapical surgery? And then we should look at the amount of the remaining coronal tooth structure in terms of height, the width, and the distribution of the remaining dentine. Does it have an adequate ferrule all around? Then we look at the occlusal forces affecting this tooth. Are there any occlusal interferences? Does the patient have parafunctional habits? Is the patient bruxist? Do I have enough interocclusal space to restore this tooth? Does the patient have temporomandibular joint disorders? And then we should look at the function of this tooth in the dental arch. Is it going to be restored as a single unit, or is it going to be an abutment for a fixed or a removable prosthesis? And then we should look at the aesthetic considerations for this tooth. Is it an anterior tooth? Does the patient have a high lip line? And then the aesthetics, is the patient have aesthetic considerations that we should keep in mind when restoring this tooth? For example, look at this mandibular canine. It has lost 3/4 of its bone support, and we don't think that this tooth is savable. It's a hopeless tooth that needs to go. It has been root canal treated. The root canal treatment is short, but it's doable. We can do a better root canal treatment for this tooth, but the question is this tooth, is it going to last in the patient's mouth with the grade 3 mobility, with this amount of bone loss? No, then extraction would be a better option for this patient. Now, why are we discussing the restoration of root-filled teeth in particular? Are they different from their vital counterparts? Of course, they are different, and these are the main differences. The most important and critical factor that makes a root canal treated tooth different from a vital tooth, and when we restore a root canal treated tooth, we should be extra careful, is the loss of tooth structure and the architectural changes of a tooth after undergoing a root canal treatment. This is a very important factor. And when you do the roof of the pulp chamber, okay, it acts like a bridge that connects the buccal side with the lingual side, and it connects the mesial side with the distal side. When we do root canal treatment, we de-roof the pulp chamber. We remove this roof, and then the cusps becomes free to move, and any occlusal force that will affect or that will act on this tooth will act like, and it will make a wedging effect, and it will increase the cusp flexure. Okay, I want you to keep in mind this term, the cuspal flexure. Root canal treated teeth have more cusp flexure than vital unrestored teeth because of loss of the roof of the pulp chamber. Another important factor are the marginal ridges. Marginal ridges are very important anatomical landmarks or features for the teeth. They help with the dissipation of occlusal forces. If one or both marginal occlusal or marginal ridges are lost, then the tooth becomes weaker and it won't act the same way as if they were present. Okay. Axis cavity itself has only minor effect on decreasing cuspal strength if it's only an axis cavity, but when one or both of the marginal ridges are lost, then the strength of the tooth is reduced significantly. Added to this factor is when you do root canal treatment, you're removing from the radicular dentine. Therefore, the tooth will lose even more of its structure. Also, if the tooth is, for example, is very weak and it needs a post placement, then we will have to remove even more of the root dentine. And this will in turn makes the tooth even weaker. So architectural changes and loss of tooth structure, this is the very important factor that makes the behavior of root-filled teeth different from the vital teeth. A study investigated the effect of different cavity designs on the and different restorative procedures on the stiffness of the tooth. They found that if you do an axis cavity only, then the stiffness of the tooth is reduced by 5%. However, a class 1 cavity that extends to the whole occlusal surface of the tooth will reduce the stiffness of the tooth by 20%. If the tooth lost one marginal ridge, then the stiffness of the tooth will be reduced by 46%. And what reduces the stiffness of the tooth the most is when it loses both marginal ridges. Okay, so marginal ridges are very important for the integrity of the tooth, and therefore you should preserve the marginal ridges unless they are involved in caries. Okay. Another factor that makes root-filled teeth different from vital teeth is loss of proprioception. You know that most proprioception comes from the periodontal ligament surrounding the tooth. However, there is a sensory feedback and proprioception that comes from the pulp itself as well. So when the pulp is removed and when the tooth is root canal treated, it loses part of its proprioception, which will result in a higher pain threshold of the root-filled teeth. So when you bite on something hard, you won't feel the same amount of pressure on a root canal treated tooth as you would feel it on a vital tooth, because and this will lead on more increased force on the root-filled teeth, and this will impair the tooth's ability to prevent mechanical overload and may eventually lead to fractures of the teeth. Another factor is moisture loss or loss of free water. the dentine and the dentinal tubules and matrix contain water, and this water facilitates the dissipation of occlusal forces. When we do root canal treatment, the pulp complex is removed, and as you know, the pulp complex mainly composed of water. So root-filled teeth have reduced free water content within dentine matrix and the tubules, and this will affect the elasticity of the tooth and may contribute to root fracture. But this is a debatable issue. Some studies showed that there is no significant difference in the moisture content between root canal treated teeth and vital teeth, and some studies showed that the moisture loss has no significant effect on the elasticity and the hardness of the tooth. Therefore, it remains a debatable issue. Another factor is the altered physical characteristics and the biomechanical behavior of the tooth. As a result of using different chemicals during endodontic treatment, we use sodium hypochlorite and EDTA, we use calcium hydroxide as an intracanal medicament. These will all affect the flexural strength and the modulus elasticity of dentine, these chemicals, okay? And they will lead to alteration in the collagen cross-linking of endodontically treated teeth and will reduce the tensile strength of the tooth. And therefore, the tooth will not behave the same way. It won't have the elasticity as a vital tooth. And this also makes the tooth weaker. Again, it's also a debatable issue. Another and the last factor that makes root canal treated teeth different from vital teeth is the aesthetic changes as a result of endodontic treatment. If root canal filling materials, sealers, gutta percha were left in the pulp chamber, this will lead to darkening and change in the color of the tooth. Therefore, it needs more, for example, internal bleaching or another procedure to improve and enhance its aesthetics, especially if it was an anterior tooth. Sometimes for the traumatized, immature teeth, we try to keep the vitality of the tooth by doing vital pulp therapy, pulpotomy, or direct pulp capping. We use calcium silicate materials such as MTA, and these materials have been found to cause staining and discoloration of the teeth. Therefore, we may consider a different restoration for a tooth that has undergone a root canal treatment. Now, when deciding the most appropriate restoration for the tooth, we want to do root canal treatment on. What are the objectives to consider? So, what do you want from your coronal restoration? We wanted to protect the remaining tooth structure against fracture by minimizing cuspal flexure. We want the coronal restoration to provide a coronal seal and protect against marginal leakage and caries. We wanted to provide satisfactory function and aesthetics. We wanted to give the tooth to restore the occlusal stability and provide adequate contact points with the adjacent teeth, because if not done properly, you will have gaps and the teeth will start moving and over-erupting. So the restoration should provide occlusal stability and adequate contact points to prevent tooth drifting and tooth movement. And also you want this restoration to ensure the health of the marginal periodontal tissues and to respect the biologic width. So your restoration should not invade the biologic width. What is the biologic width? It's the sum of the connective tissue and the epithelial attachment around the tooth. It's been estimated that it is around just more than 2 millimeters. So it has been advised that you should keep at least 3 millimeters between the margin of your restoration and the crest of the alveolar bone. There should be a 3 millimeter distance between the alveolar bone, the crest of the alveolar bone, and the margin of your restoration. This figure and this number was derived from a human autopsy study by Gargiulo in 1961. They found that the average connective tissue attachment for a tooth is around 1.07 millimeters, and the average epithelial attachment is around 0.97 millimeters, and the sulcus depth is around 0.69 millimeters. So in total, we should leave 3 millimeters between the crest of the alveolar bone and the margin of our restoration. What happens if you invade the biologic width? The biologic width will tend to establish itself, and depending on the tissue type, the gingival tissue type of the patient, the patient will have different outcomes. So if the patient have a thin gingival biotype, you will have recession around the margins of the crowns. Okay, a few weeks later, you will put these crowns, and then a few weeks later, when you bring the patient back, you will see the gum has receded and the patient will have aesthetic problems. If you invade the biologic width by your restoration and the patient has a thick gingival biotype, then you will have enlargement and swelling of the gingiva around the restorations, and again, this isn't aesthetically pleasing. Okay? So we should respect the biologic width, and we should maintain 3 millimeter distance between the margin of our restoration and the crest of the alveolar bone. What if you don't have enough tooth structure coronally and you want to save this tooth? You have two options, mainly surgical crown lengthening, in which you remove part of the gingiva and part of the bone and expose more of the tooth structure. You expose part of the root, and then you will have enough tooth structure to put your restoration margin on. Or else you can do orthodontic extrusion. You can move the tooth coronally and provide more tooth structure. Of course, it takes time, and it's an extra commitment, financial and time-wise, for the patient. But if a patient is keen to save the tooth, then you can offer them these treatment options. You know by now the importance of the coronal seal and the the negative impact of coronal leakage on the root canal treatment. So if you have a good endodontic treatment and you don't provide a good coronal seal against leakage, then the treatment will eventually fail. What's the best time to place the definitive restoration for your tooth after doing root canal treatment? The best time is as soon as practical. If you can place the restoration on the visit that you've completed your root canal treatment, then this is good. Okay, so as soon as practical, you should provide the definitive restoration, because unrestored or improperly temporized root canal treated teeth are weak and susceptible to fracture and to coronal leakage. The best temporary restoration will not last for more than few weeks. Okay, so you should replace the temporary restoration as soon as possible with a definitive, stronger, better restoration that offers better mechanical properties. Some would say that, oh, let's wait until the tooth heals and until we see signs of periapical healing. This is nonsense, because healing of the periapical lesion may take years, and it's not practical to wait until then. And if you wait until you see signs of healing, then the temporary restoration will cause leakage and the tooth may fracture, and the endodontic treatment will fail. Okay, so the best time to provide the definitive restoration is as soon as practical. This study, it's a retrospective study that investigated the influence of the timing of, or the time lapse between root canal treatment and the corona restoration placement, and they found that the best time is within 4 months. If you leave the tooth without cuspal coverage for 4 months or more, then this will increase the chance of the tooth being extracted by 3 times. So the restoration should be placed as soon as the root canal treatment is completed. Proper temporization is also important. For teeth that has lost both marginal ridges, we should do a build-up, and we should enforce the tooth with a stainless steel band cemented with glass ionomer cement to reduce cusp flexure and to reduce the chances of tooth being fractured. So orthodontic bands are useful, cemented with glass ionomer, to increase the survival and to enhance the survival of root canal treated teeth between appointments. Some of the temporary restorations will also undergo hygroscopic expansion, leading to increased chances of fracture. So I'll go back a few slides to this premolar that has only a temporary restoration on the occlusal surface, and it has fractured, the palatal cusp has fractured, and that's most likely because of the hygroscopic expansion of the temporary restoration that has led to wedging forces on the cusps, and eventually the tooth has fractured. Let's discuss some examples on restoration of root canal treated teeth. We'll take the teeth as individuals. For anterior teeth, if you only have the palatal part affected, then and the coronal structure is largely intact, then a composite restoration on the palatal surface will be enough to restore your access cavity. However, if the tooth was badly destructed or if the patient has aesthetic concerns, for example, this patient has fracture, half of the tooth has fractured and the other half has undergone discoloration, it became darker, internal bleaching did not work, then we can give this patient a crown restoration. And you know, the lithium disilicate crowns, they don't require too much occlusal or reduction in general, so we can provide this patient with good aesthetics and at the same time preserve as much as we can of the tooth structure. For posterior teeth, the success rate of or the survival of posterior teeth that has been root canal treated is improved by 6 folds when you place a crown restoration on them. So cuspal coverage is very important for posterior teeth, premolars and molars. Cuspal coverage, it doesn't always mean a crown restoration. It may mean an onlay that's done by composite, direct composite or amalgam, or an indirect onlay that is done by from porcelain or metal in the lab. So cuspal coverage is very important to strengthen and to protect the weakened cusps of posterior teeth following root canal treatment. In this photograph, you will see an onlay that was prepared or made with amalgam. Okay? But when the access cavity only involves the occlusal surface of the tooth and it's a conservative access cavity, then a direct composite restoration is enough. Okay? This is another example. This tooth has undergone root canal treatment. The tooth was still symptomatic. The access cavity was conservative and it's done only on the occlusal surface. Both marginal ridges are intact. the root canal treatment was redone, and the tooth was restored with direct composite. Okay. Another example, this patient came complaining of pain on biting. The pain was localized to these three teeth, the premolars and the first molar. These were root canal treated. The root canal treatment quality is poor. There are missed canals, there are remaining caries, short root filling, missed MB2. So we decided to do a root canal retreatment. Of course, we removed all of the restorations and the caries underneath. We did a build-up for the teeth. We root canal treated them. That was done for the premolars and the molars. The teeth were then prepared for cuspal coverage restorations because the marginal ridges were affected. One marginal ridge was missing for both the first premolar and the first molar, and both marginal ridges were lost in the second premolar. The decision was to restore these teeth with indirect lithium disilicate onlays. These teeth were restored with the restorations, and this is the post-operative radiograph.